I'll try to be succinct. When we talk about rehabilitation of the brachial plexus, it's always good to start with nomenclature. And Narakas gave us that. We have basically categories, right? Some categories require some surgery, some don't require surgery. So upper herbs, extended herbs, usually you don't need to mess around with those. Total policy, with or without horns, you should do a surgery. Let's break those down into categories. So non-surgical and post-surgical, because they're going to get a surgeon, they're still going to come back to you. When you look at those cases, Narakas 1, 80 to 90% are going to do well, and they might not just need a little rehab. That much need rehab, that little red, right? Narakas 2, 30% need rehab. Narakas 3, 50%. Narakas 4, almost all will need rehabilitation. Now, when you start thinking about rehab, you don't want to just start doing rehab on a person who might require a surgery. So beware of mimics. This is the first case in the world described of what we thought was bilateral brachial plexus injury. It's actually a C5 root avulsion. You can see the pseudomeningoceles there. It kind of confounded us for about a few hours. Then we figured out, oh no, it should be spinal cord, and that's what it was. When you look at these cases, you have to have a measure that tells you things are changing. You can't just believe what the family says or what you're seeing. The active movement scale was made about 20 years ago in Canada. It's an onerous scale, but it's quite good. It gets every single movement on a scale of 0 to 7. I like the Quest scale. It's made more for cerebral palsy, but it tracks it down to the joint and muscle. Again, made for cerebral palsy, validated for that purpose, but I use it this way. Electrophysiology is what we all like to hear about, and in the first month from the injury, NCS is useless. We know that. At 1 month, you could look at the axon viability index, and if you look at the axillary nerve, it can predict that they're going to get co-activation. This is the first publication in the world to show that. You want to be able to predict who's going to get problems so you can start counseling the family in advance. But NCS at 1 month. If you have a normal CMAP, wonderful. Easy case. If it's a partial CMAP, or the CMAP is not elicitable, but the baby is moving their arm, you're going to have complications. And if there's no CMAP and there's no movement, wait until 3 months. At 3 months, if there's no elbow flexion and the CMAP still can't be found, really think about getting a surgeon, getting an MRI. It's not that hard, it can be done. I'm going to contradict myself now, because if you wait till 6 months, 85% of these biceps will improve. And this kind of bothers our surgeons, but it's what it is. I mean, these kids can still heal, even though we think they're not gonna. What is the goal of therapy? What's the goal of treating these kids? You want to form an aesthetic motor engram, not just have them do something they do in a way that looks normal so no one else makes fun of them, so they feel good about themselves. They should take that aesthetic motor engram and use it in daily life. And this is where cost comes in. They're going to do this 10,000 times with selective voluntary motor control to make it their own movement the way it should be. And for that we have prerequisites. They should have insight and the desire to change, which no baby has. They want to have fun. They don't want to be doing something because someone told them to, or they don't have a desire or understand that they should be doing something for a reason, right? So until then, until they get that insight, keep all the joints supple, watch for awareness of problems to improve, and then train function as much as you can. And that's what we deal with. The main obstacle we face is how does that child perceive their limb? In the best case, these kids will see it as a helper limb. It's not a bad thing, but it can't do everything. Some ignore the limb. And if they do, okay. I mean, wait for them to develop insight, the desire to improve, fine. Some kids, you look at the arm, you touch the arm, they scream bloody murder. This is the problem. But the worst is where the entire arm is deafferentated and it's a pain generator. They start biting the hand because it's hurting so much, this stops the pain. This is what we deal with. Children will be children, you can't make them do anything, so your prescription has to consider. You have parents caught between their expectations, how the baby responds, and their healing physiology. Home care is the mainstay because you really need someone to do this over and over and over again. High quality repetition and therapy, right? And that the best people are the parents. But again, there's prerequisites. So the parents should be mature. They should not get emotionally blackmailed by a baby who keeps on crying when they touch the hand. And it happens. People do get upset. People like to laugh at each other behind their backs. And again, they should not be bothered by social stresses. Again, it's a high cost to ask. Another thing is, they should understand that it's not going to suddenly get better. This therapy does not equal that gain. It's just kind of, we make progress, we reassess, we make progress, we reassess, and we keep pushing until we get to where we can. So, rehabilitation of non-surgical cases for the first year. You have a brain, you have an anterior horn cell, you have an axon. For the first 3 months, the brain is wondering, hey, there was a hand there, where did it go? Why are the muscles not working anymore? And the clinical problems we face are, they don't move some muscles. And this leads to an uninhibited pectoralis major. So how do we treat it? Passive range of movement, prevent contractures, sensory integration via myofascial chains, and watch for muscle action. And from there, at 4 to 6 months, the brain is really looking, where did that muscle go? Why is it not working? How can we use it? How can we make things happen? By this point, you expect deltoid to be innervated. It should really be acting. But the clinical problems we face, again, are an overactive pectoralis major making internal rotation deformity. And how do we treat? Everything I've said before. Then movement training. We now have systematic reviews that show us modified CAMT can actually really help this. The parents always fight us on this. They have all kinds of concerns, but it is a good therapy to do. At 7 to 9 months, we really expect bicep and tricep teres minor to be acting. So the brain is really scrutinizing, how can I use the muscles that I have? And the problems really start to get bad here, because if they're not doing rehab properly, you'll find a pseudohypertrophic biceps. It might even cause a radial head subluxation. Co-activation, what our friends were calling co-contraction, emerges in this time frame. So again, at 1 month, if you can predict that it's going to happen, you can try to prevent it, high-quality rehabilitation. But if it's happening, you know it's there and you know it's coming. And of course, winging of the scapula. So how do we treat? Again, constraint-induced movement therapy, try to train function, and of course we have studies that show us Botox can help. This is the first study in the world to actually show us that CIMT with Botox will help. We didn't know how to publish in those days, so I went to a nonsense journal. But this is a child who had a brachioplexus palsy. Her arm is in a immobilizer, that's why it's behind, and it's her involved hand affected. Let's see if this video works. We're not getting video. How do I get the video? Sorry, I'm in the wrong place. Huh? How do I go backwards? Okay. So can someone start the video for me? Can you start this video? I'm not able to start it. Is this it? Can I start from here? The video should be there. She's immobilized, her good hand is held back, that's her involved hand. She can shoulder flex forward and grab stuff. Mom comes in to get involved. Watch the shoulder. That is co-activation. She has full passive range of movement, but she can't abduct beyond 90 because pectoralis major, latissimus dorsi are inhibiting it. And we remove that brace, and now watch her. Pretty much normal function. So this is what you're expecting when you train function. So by 10 to 12 months, the problems we face again are co-activation that's still emerging or not going away. But now we get glenohumeral dysplasia, where the acetabular labrum, the glenoid labrum has not formed properly because the shoulder's always sat in this position, and now it clicks. And how do we treat this? Everything I've said before, Botox, and supinator should be working by this point, but watch the shoulder and the elbow very carefully. I don't know if you saw that snap. That is actually the head of the humerus slipping back into the labrum. There it is. So these are a mess. And this is again where they're not doing rehabilitation properly or the lesion is that bad, one of the two. Ages 1 to 4, the brain is now going to figure out how to get things done because it has to get stuff done and they have to live and enjoy. So it's just going to find ways to get stuff done. And this is where we find disuse apraxia. Insight emerges, supination develops, but the affected limb is now either a helper or it's just ignored. How do we treat it? This is the first time I'll get a therapist involved because here you want someone to go hand over hand with that patient and make them do tasks. And they'll usually fight the parents at this stage. Non-surgical, ages 5 to 10. So affected limb is used for tasks in a non-aesthetic way, and no one is happy with it, but they have a hand, they can use it. This is one of my girls who's just come back recently. Watch her put her hand on her hip. What you're seeing is a mallet score. It's a stick. You'll see it in a better way in the next video. But she had actually twisted her trunk to get herself there because those muscles were so weak. This is the same muscles drawn out on this different child's back. And you watch them carefully, you'll see how you see the problem. You can see the winging, you can see the scapula move abnormally. You can see the inferior pole sticking out the lateral end, which it should not do. But that's just how weak those muscles are, that's how bad the imbalance is. So how do we treat? Selective muscle retraining, and then definitely we're going to think about surgery here. When we look at post-surgical cases, our surgeons told us about this, I'm not going to repeat, but there's always this lag, and the lag is the age at which you operate versus the time to regrow down to those neuromuscular junctions. So again, the longer you wait, and this is the problem we have over and over again, how early do you operate? Because if you operate too late, it's that much more time to grow down to that neuromuscular junction. If you go early, could you have gained something? It's still a toss-up, so clinical exam is everything. But either way, pre-op and post-op rehab will be as it is, and we're going to keep working on transferring or retraining muscles. The tricky part is, if you do an early nerve surgery, you'll get about 80% of your biceps to become normal. Not 100%, 80%. But regardless, you're always going to have an incomplete function. And that's just the toss-up in this. It's that much of a mess trying to figure out how to help people. Nerve transfers and neurotization, our colleagues have told us already, and the time of operation will be 6 to 9 months. There's a 4-week lag where you can't really use the limb, and then things start to work. But this is a much better operation, it's much more specific. Pre-op, post-op rehab is the same, and the goals are pretty much the same, train function. The problem we have is the problem with all nerve surgeries. 33% of the axons that you anastomosed will do what you want them to. They'll grow to the neuromuscular junction, they'll do their job. 33% will grow backwards and become useless, 33% join motor to sensory and again become useless. At best, you're going to get 50% of what you transferred to go down and do its job. And this is the problem. But what do you do? It's still good surgeries. There's also muscle surgeries. I believe we didn't talk about that. Mod quad is a common one. So when you have a glenohumeral dysplasia, you're going to think about that. You're going to look for contractures also and treat those. Preschool is the time for this. There's no lag to the neuromuscular junction. It's just what it is. And again, once the cast is up, work on getting the muscles to work better. We get a lot of frequently asked questions. So many people are up in the air. Should we operate? Should we not? They come between their center, our center. Should we do a surgery? Should we not? We're scared. We're afraid. Someone said physio is enough. Is that correct? Do an NCS. If the NCS is normal, I wouldn't argue them too much. They might need Botox later on, but otherwise you really do want to be thinking about keeping surgeons online and ready. Some families say, hey, he's really improving. Why should you do any more than just physical therapy? And again, the NCS will predict and tell you if they're going to have co-activation emerging. The therapists often don't know what this is or how to get to it. I'm assuming your colleagues might know how to, but most don't have an actual idea of what this is, so they keep saying more therapy, more therapy. Someone said oil massage is really good, and if the arm is rusty, I would definitely do it. We don't see rust on arms, so if it makes the family happy to oil the limb, do it, but please do the exercise we show you. If we operate, will it be 100% success? This child will always need rehabilitation. Is it time for electrical therapy? The answer always is the correct way is where your child can contract after that shock. And if not, then the therapist should be assisting them when that shock happens. Do it properly or don't do it. Some families come back and insist, hey, they're actually better, but they're really worse. So the response we give them is, in the last encounter with this many movements, you refuse the advised treatment, now she's lost more function. How do you want to proceed? These are kind of aggressive answers, but what to do? They should understand what they're getting into. There's economics involved too. This is someone else's life, right? So proper care versus later care or no care. Lifelong deformity. Pretty straightforward. Home exercises versus physical therapy. Home exercise is relatively free. Physical therapy, depending on where and how you do it, 3 times a week, could be about 3,000 rupees. And again, how many therapists really understand this? It's hard to say. Botox on time versus not. They'll save the cost of Botox, but they'll have lifelong deformities or definitely need more surgery. We do have studies showing that if you use Botox early on, you don't need as bad a surgery later on. Botox on time versus late Botox. You can have a deformity and less function, but it'll be better. Botox versus surgery later. You pay what the surgery cost. The thing is, it's never that straightforward. You have a young family, they may not always have money. There's societal pressures, there's fear, there's so many things that come into play. We don't have a lot of EBM on this. There's not too many RCTs, there's systematic reviews, meta-analysis showing us how you can move forward in a safe way. So it's very much their maturity and what they're looking to get into. The biggest question I get from all our physiatrists is, if I do this, how am I better than a physical therapist? You do your best for the patient, the rest will sort itself out. Our colleagues just want good outcomes. They don't care how we do so, they just want to make sure that we get the patient the right thing. If you give them that, they'll want to acknowledge you. Most people are decent. If you pass the care over to a therapist, you lose information, you lose patient confidence, and you lose clinical skills all in one go. And referring doctors will see you do that and they'll do the same thing. You're just a stop sign now. That's all.
Are open for discussion. So I invite all the rest 4 speakers to onto the stage. Any questions from the audience?
Can you explain that? What is the mechanism?
This is tricky. So it's not your, I'll have to show you in a photo. Essentially, there's such bad internal rotation with pectoralis major that this whole thing will stay in an elbow flexion position, even though biceps is deinnervated. So this entire short head will activate in such a way you see the whole thing sticking up in the arm internally rotated. That's roughly what it is. It's not that it's actually active, it's just held in a position where it can artificially shorten. And if it gets really bad, then you find the radial head subluxing.
I got a patient like that.
Yeah.
And now the child is actually end up with the lengthening of the biceps.
Yeah.
Thank you.
Difficult to comprehend, and most of our physiatrists, I don't think have been exposed much to, except if they're working in a hand injury center. I worked in Stanley Medical College in the hand department, so they have been doing this cross C7 for adults. So this is the first thing I heard that you're doing it for the babies. So,
we are the only center, and another in Turkey and one in Philadelphia, USA. So only retroesophageal hook, that is the, because there are centers who take contralateral C7, but they take it through the subcutaneous route, which needs a very long graft, so that the
It's a
cell will
longer
be
time to
regenerate.
regenerate. So congratulations to your team.
Thank you.
And I'd like to ask Dr. Jimmy Jose, you've been talking about bone marrow and adipose tissue. Where exactly do you take the adipose tissue from?
Usually, as you saw in the video, it's usually from the abdominal fat,
From the
but you can
abdominal
take it from even the thigh or anywhere else.
Okay. And how many sittings do you get? And usually PRP.
So basically, I
needs two or
haven't
three.
really started doing bone marrow or adipose tissue yet. So I've just presented it. I'm doing only PRP and prolotherapy for now, but I've attended workshops where I've seen such things. So it's just a presentation on, I haven't started doing adipose
So I
tissue.
think the
or
postgraduates
bone marrow yet,
please noted that you can take it up as
Yes,
your thesis and start
definitely,
working
all the
on it.
institutions should definitely take this up as a research topic for your PGs and start doing, because there's a lot of research everywhere. I mean, a lot of already results are there, and all the institutions should definitely start doing research on bone marrow and adipose tissue, definitely.
Prolotherapy hasn't given much results like from what we have done.
Maybe the technique is wrong, but prolotherapy definitely has a lot of good results. I think.
In our state, even the orthopedicians are doing it, and in fact, they've given it up. Saying in
that's-
the long term, it's not giving.
Maybe
they come back with pain again.
Maybe they are doing it the wrong way. I don't know. I think Dr. Ravi or Dr. Shashi Kumar sir might be able to, because there are really good results.
Dr. Ravi's comment. Prolotherapy.
With my students, I always use this gold standard. Is this condition due to deficiency of that therapeutic? So there's no condition due to deficiency of prolotherapy. So if you do prolo and you get a good result, we're all happy. If you get a bad result, you have to ask yourself why. The most common reason is the scapula is sitting anterior and inferior, right? Or adducted. Why is that? Because the tissus dorsi is overstretched. Everybody looks at the shoulder joint, they don't look at these muscles acting on the scapula. So if you fix all of that, you fix the pot belly, you get the posture corrected, they can actually do quite well. It's just everybody gets stuck on intervention and they miss the person as a whole.
Now, brachial plexus. How does it help?
So we are injecting the overacting muscles. So we take a baby to anesthesia, we knock them out, and then we hit pectoralis major, latissimus dorsi, subscapularis, and maybe pronator teres. When you artificially weaken those overactive muscles, provided the other guys are innervated, they can start acting. And then restore the muscle balance across the joint.
We have to rule out contractures also.
This would all be ruled out in advance. And again, we hope the parents are doing the proper thing. There's always a degree of muscle shortening that you cannot account for. And what the clue is, when you have them abducted, the entire scapula pops off the thoracic cavity, the muscles like subscapula are really short. So we would have them do that before you do that. But nonetheless, it does work quite well. So full contractures, no. Possible some contractures, it still helps.
Any more questions from the floor? Dinner or something? Thank you very much, all of you. It was a wonderful presentation. Thank you.
To Dr. Suresh Rajagopal, sir.
Backward. സെൻറ്റർ വരാൻ പറ സെൻറ്റർ
May I now request Dr. P.S. Suresh Kumar sir to kindly present a memento to Dr. Jimmy Jose. May I now request Dr. J. Geeta Kalpana ma'am to kindly present a memento to Dr. Vino Roy. May I now request Dr. Ramaswamy Pilla sir to kindly present a memento to Dr. Ajay K.S. May I now request Dr. P.S. Suresh Kumar sir to kindly present a memento to Dr. Ravi Sankaran.
മാഡത്തിനോട് അടുത്തിരിക്കാൻ പറഞ്ഞു.
May I now request Dr. George Matthew sir to kindly present a memento as a token of our gratitude to chairs of the session. Dr. Ramaswamy Pilla sir. Dr. P.S. Suresh Kumar sir. Dr. J. Geeta Kalpana ma'am. We extend our heartfelt thanks to all the speakers for the insightful presentation and to the chairpersons for skillfully conducting the session. Thank you all for your active participation. Members of the Kerala